for it. So welcome to today's webinar. My name is Lindsay Bills. I'm a field marketing specialist for Axonics, and I will be moderating this webinar. This evening, Dr. Kaaki will be speaking about bladder and bowel dysfunction, the common symptoms patients experience, and treatment options available that may help patients gain control. So without further ado, I would like to introduce Dr. Kaaki.
Hi, everyone. Lindsay, can you hear me okay?
I can, yes.
All right. Well, let me then share my screen and begin the presentation. All right. So thank you for joining our community health talk to regain control of your bladder and bowel. My name is Bilal Kaaki. I work at the Riverside Multispecialty Medical Group. I practice both at Riverside and Pomona. Have you ever thought about drinking less before going out on a trip? Or have you thought of, oh, I missed this best part of the show or a movie, or before leaving your house, you needed to know where all the bathrooms are, otherwise you worry that you won't make it? Well, bladder and bowel symptoms can be very disruptive to your quality of life, but you are not alone. Many Americans, 50 million in the United States, have overactive bladder, and an additional 20 million suffers from fecal incontinence. And that's what we're going to be discussing in our talk today. The interesting thing is that only half of those with severe symptoms seek treatment. And there are barriers for that, and we will discuss this later in our presentation today. So let's delve deeper into these conditions. Common entities are overactive bladder, urinary retention, and fecal incontinence. So some of the symptoms of the bowel and bladder are due to these conditions. So what is overactive bladder? Overactive bladder is the sudden urge and the sensation that you need to urinate, and you are unable to defer and unable to hold it or control it. Urinary retention, on the other hand, it's the other way around. It's difficulty urinating and a feeling of incomplete bladder emptying. And for the bowel, fecal incontinence, it's the involuntary loss of stool. So what's the function of the bladder? The bladder has two functions. One is to store the urine, and the second function is to empty the urine. So throughout the day, the bladder would be filling, and that's the storage. And the rate of filling depends on how much you're drinking. And then when the bladder gets distended, there are nerve signals that goes to the brain that lets you know that it's time to urinate. And then when it is socially appropriate and upon your control, when you decide to urinate, then there are nerve signals that goes from the brain through the spinal cord that goes into the bladder and contracts the bladder, and then relax the urethra and the pelvic muscles for the urine to come out. And that's the emptying. So there's the storage and voiding phase. So that's the normal bladder function. Now with overactive bladder, or it's called OAB, the abbreviation for it, it's the frequent and the urge need to empty your bladder. So some of the common symptoms of overactive bladder are urinary frequency, urinary urgency, urgency incontinence, and nocturia. Now, not all these symptoms need to happen for overactive bladder. For example, someone could have urinary frequency and urgency. That's called urgency frequency syndrome without leakage, and that's overactive bladder. Or another term is overactive bladder dry. Whereas overactive bladder wet, that's when you have these symptoms along with urgency incontinence. So urinary frequency is usually urinating more than 8 times a day, so urinating frequently. Whereas urinary urgency is the feeling of a sudden urge to urinate that's difficult to defer and control. Urgency incontinence is the loss of urine from urinary urgency. And nocturia is waking up more than 2 times at night. So with overactive bladder, we spoke about normal bladder function. So what happens with overactive bladder? With overactive bladder, these symptoms that we mentioned, the frequency, urgency incontinence, nocturia, happens because there's an abnormal communication between the brain and the bladder. Like we discussed, when it's time to urinate, there are signals that goes through from the bladder to the spinal cord to the brain, let your brain know that you are the bladder is full. So with overactive bladder, there are false signals. So even when the bladder is not full, there's just a little bit of urine that it's irritating the bladder. False signal that the bladder is full. You go, so that's why you go frequently, or you get like this strong urge. And we with the normal bladder function, we mentioned that when it's time to urinate, it's under your control and it's socially appropriate. There are signals from the brain to the spinal cord that would contract the muscle. So with urgency incontinence or OAB wet, you get this sudden urge or the urinary urgency, and there will be an uncontrollable or unwanted bladder contraction beyond your control, and that would lead to the leakage. So you may need to rush to the restroom and lose the urine. That's urgency incontinence. There are different types of urinary incontinence or leakage. So not all leakage is the result of overactive bladder or urgency incontinence. But the two main types are stress incontinence and urgency incontinence, or OAB wet. With stress incontinence, it's due to the lack of support to the pelvic floor. So you tend to leak when you're coughing, laughing, or moving upon exertion. So this increase in the abdominal pressure gets transmitted to the pelvic floor, and because there's lack of support in the pelvic floor, there's loss of urine. And typically happens with younger women, and it's associated with prolapse sometimes, related to childbirth. Whereas urgency incontinence, it's more of a neurological component or disease. So there's a nerve issue. And there's a lot of patients that have a combination of both the urgency incontinence and the stress incontinence, and it's called mixed urinary incontinence. Moving on to the bowel function. I know that's a lot of information. Well, the bowel, especially the rectum, has a similar function to the bladder. So we mentioned with the bladder two things: the storage, so the bowel store the stool, and evacuation, to empty the bowel movements. So as the rectum fills, there are stretch receptors in the wall of the colon that gets activated, and there are nerve signals that being sent to the brain make you feel that, oh, it's time to empty the bowel and to do, number 2. And then when also it is socially acceptable and upon your control to pass bowel movement, defecate, then nerve signal goes from the brain to the spinal cord and relax the pelvic floor muscles and the muscle in the rectum to push the stool out. With fecal incontinence, there is uncontrolled loss of stool, whether it's solid, liquid, or mucus. And similar to overactive bladder, there are symptoms. So symptoms for the fecal incontinence are fecal urgency, when there's a sudden urge to pass stool. Urgency fecal incontinence, that when is beyond the urgency that you get to pass bowel movement, eventually you will lose the stool without your control. And another type of incontinence is passive fecal incontinence, or the leakage of stool with activity or without you being aware. And that's typically you're not aware of it, you just see it on your underwear or pad, and it could be like smearing or soiling. So as we mentioned, bowel and bladder dysfunction has a major impact on the quality of life, on the physical aspect. So it would limit physical activity. So a lot of patients are unable to exercise, whether they want to lose weight or just stay healthy. It just limits them participating in sports or going to the gym. Has a social impact. So because of frequent trips to the bathrooms, you then feel like you're unable to go out and watch a movie, go out for dinner, and it will also restrict travel. So planning for travel would be an issue. It has an impact on your psyche, so psychological. You will feel depressed because you're missing out on the social activity, etc., and feel ashamed or guilty. And it does affect the body image, and hence you lose self-respect because you're always afraid that when is the accident is going to happen, or if you're going to make it to the bathroom or not. So it's very distressing. It has a impact on your sex life, so sexual impact. Same thing due to the self-awareness of the body image. So you avoid having sexual relationship, and it affects intimacy with the partner. Impact on professional, on your work life and occupation, and makes you have frequent breaks, disrupt work, even being absent from work, and decrease productivity. And even at home, so domestic impact, doing house chores, needing to get special bedding with severe symptoms. So we mentioned that early on in the presentation that less than half or very few would seek treatment, and because there are barriers and barriers, and I would say more like misconception. And these misconceptions are not just in the general public, but also in the medical community. So I've had discussions with multiple physicians where they think that having leakage is normal part of getting older. No, it's not. Not everyone who is 70 or 80-year-old have incontinence. A lot of patients have, but not everyone. So it's not normal, or just normal part of being a woman. Another misconception. Or with men if they have prostate. Or you feel like you've done something wrong. In addition to the barriers, it is a somewhat, I don't want to say a taboo, but it's hard to bring it up. So many patients will suffer in silence for many years, believe it or not, before they bring it up to the physician. And what's even worse is that sometimes when they bring it up, they get brushed off by their physicians because they are very busy managing other issues with like diabetes and hypertension, or because of these misconceptions that that's a normal part of aging, rather than getting referred to a specialist. So it's important to know that there are treatment to help you gain control over your bladder and bowel. So don't settle to live that way and have a lower quality of life. So many treatment options, and we'll go over them one by one. There's a care pathway. So you consult with a doctor, you get an initial treatment, and then you follow up with a doctor. And if that doesn't work, the initial treatment, then you move on to advanced therapies. Now, another problem with getting treatment, a lot of patients get lost to follow up, and this is very important. So the first step is to consult with the doctor to get a referral if the primary care is not comfortable discussing or managing bladder and bowel dysfunction, where you get a baseline of the symptoms. So for overactive bladder, we do a bladder diary over a course of 3 days. We write down how many times you go to the bathroom, if there's any leakage, etc. There are a few tests that can be done for diagnosis, whether taking a look with a camera at the bladder, doing a urine test. And there are conservative therapy that we start off with, which is behavioral modification, bladder training exercises, lifestyle changes, fluid restrictions. Second line therapy would be to start medications. And that's when a lot of patients get lost to follow-up, is that they feel like it's not working, nothing is working, so they lose hope or trust, and they lose follow-up, which is very important, because besides this initial treatment, there are more advanced therapy like sacral neuromodulation, and we'll discuss what that is, or percutaneous tibial nerve stimulation, or injecting Botox into the bladder called chemodenervation. For the urinary retention, similar. You discuss your symptoms, get baseline bladder function, do some testing, do what we call a post-void residual, how much urine is left in after urination. Start behavioral modification. For men, they can start alpha blockers. Same thing, there's a roadblock. A lot of time these initial treatment do not help, so patient get lost to follow-up. There's other option would be either do a intermittent self-catheterization or sacral neuromodulation. Fecal incontinence, very similar. After the assessment, you start off with initial conservative therapy with diet change, increasing fibers, sphincter and pelvic floor exercise, Imodium for antidiarrheal medication, possible pessary. And if these initial treatment work, great. If not, you advance to the next step, either sacral neuromodulation again, or surgery, which is anal sphincter repair. So let's discuss more about the initial treatment or conservative therapy for overactive bladder before moving to the advanced therapy. So we mentioned behavioral modification, that's bladder training exercises so you learn how to suppress the urge that you get through techniques with the relaxation, or pelvic floor exercise called Kegel. Bladder retraining, you do timed voiding and delayed voiding. Pelvic floor exercise can be done also with a physical therapist, where you can get biofeedback, because it's hard to control or isolate these muscles, so you can get help with feedback, whether auditory or visual, with a physical therapist, and helps you target better to exercise the right muscles. Lifestyle changes, we mentioned few, like fluid restriction. If there's a misconception, a lot of people think that they have to drink half their body in weight with fluid, or you have to drink 8 glasses of water, but at the same time they think that just water, 8 glasses, but they're drinking 3 cups of coffee, 2 sodas, alcoholic beverages, etc. Avoid Other lifestyle modification would be to avoid bladder irritants like caffeine or artificial sweeteners. We mentioned medical therapy or medications. There are two types of medical therapy for overactive bladder. Traditionally, for many years, anticholinergics, but they have a lot of side effects like dry eyes, dry mouth. Newer medications are called beta agonists like Gemtesa or Myrbetriq, and it promotes bladder relaxation. So it relaxes the detrusor muscle. As you mentioned, there are false nerve signal, so the muscle contracts, so this will relax the muscle. If these fail, we mentioned there are advanced therapy. Some of the advanced therapy would be posterior tibial nerve stimulation. Typically, that therapy has been in the office where you do 30-minute sessions weekly. And after that, after 12, one can do maintenance once a month. And recently there has been like an implant to get these therapy. Or Botox injection into the bladder. Similar to the medication, it relaxes the muscle of the bladder, but it's a little bit stronger. And some of the side effects sometimes would be the effect, it will work too much and the bladder will stop working completely for a few weeks, where you need to self-cath to empty the bladder, but just for a short period of time, because Botox, eventually the effect will go away. So actually, if it does work, then it needs to be repeated every 6 to 8 months. Sacral neuromodulation, in my opinion, is the best advanced therapy because it addresses the major issue. So overactive bladder and urgency incontinence is a nerve disease. As we mentioned, there's a problem with the signal that goes between the brain and the spinal cord all the way to the bladder. So it's not a muscular disease. The muscle of the bladder is not the issue. So that's why medications and Botox sometimes do not work, because you're just paralyzing the muscle. You are putting just a band-aid, but you're not addressing the real issue, which is a neurological issue. So with sacral neuromodulation, we stimulate the sacral nerve, which control the function of the bladder and the bowel. You can see through the picture where, let me see if my mouse would be, yeah. So that's the spinal cord where the nerves goes through up here from the brain. They go down through the spinal cord, and there are nerves that comes out, and these are the sacral nerves, sacral nerve 1, 2, and 3. So sacral nerve 3 has most of the control for both the bladder and the rectum, the bowel. And that's how it helps with urgency incontinence, urinary incontinence, and fecal incontinence. And helps you restore, so when you stimulate that nerve, help you restore the function of the bladder and the bowel by stopping these false signal that the bladder and bowel is full, and stopping these false signal that goes down to empty the bladder and bowel without your control. And a special thing about this therapy, before starting it, there is a simple in-office procedure or a trial to see if this therapy will be successful before committing to a permanent implant. And I do think that this is a special step for any therapy. The reason why I mentioned is that I do a lot of surgery. So for example, for pain, let's say if I'm doing a hysterectomy, I'm never 100% sure that if I'm going to do a hysterectomy, the pain is going to go away, because there's no test to see ahead of time. So we suspect, we make the decision, and then you'll see the results afterwards. But this one, you can see the result before you get the therapy, which is very special. And if the trial is successful, then you proceed with the permanent therapy. So axonic therapy, here's a disclaimer. So what's axonic therapy? It's sacral neuromodulation. That's the therapy that we're discussing, that help restore the function of the bladder and bowel. And it's FDA approved to treat overactive bladder, urgency incontinence, urinary retention, and fecal incontinence. So how does it work? As we mentioned, overactive bladder, urinary incontinence, urinary retention, and fecal incontinence is due to an abnormal communication with the nerve signal between the brain and the bladder and bowel. So with axonics, the sacral neuromodulation, there's stimulation of the nerves, and that helps control the bladder and bowel and restore the normal communication between the brain and the bladder and bowel. And that's how the symptoms improve. So as I mentioned, the first step is to do a test that can be done in office. What we do is we put in a numbing medication into the upper butt or lower back to the side, and we thread in a thin flexible wire called a lead through a needle that goes next to the sacral nerve, and it gets connected to an external stimulator. That's the white box you see in the picture. And the patient goes home for 3 to 7 days, where the patient can experience what the therapy will do, how much it will improve their symptoms. And they would go home with a remote control, that's the green fob, to increase the stimulation or decrease it or turn it off if needed. And there are two types of stimulators. The one on the left, the smaller one, it's rechargeable. And the one on the right, somewhat a little bit bigger, and it's recharge free. The recharge free can last between 10 to 20 years, so on average 15 years, depending on how much the stimulation. The more the stimulation is needed, the more it will drain the battery, so to be on the lower end. And it's similar to I would say a watch, but somewhat thinner. And it's placed into a pocket in the upper buttock area or lower back in the fat area. And it delivers continuous current stimulation to the nerve. And with it, no recharging is needed. Just set it and forget it. Whereas the smaller one, because it has a smaller battery, but it's designed to keep it for more than 15 years, it needs to be charged. And typically you charge it once a month, depending also on the stimulation level. And typically it's less than an hour for it to be charged. From the patient that have it, there was a study or questionnaire that found that after a year of use, that most patients found that it's easy to recharge it, that it's acceptable, the charging frequency and the duration, which is, more than once a week. So that's up to like once a month, and taking less than an hour to recharge. Both of these implants are full body MRI conditional, meaning that they're approved for full body scans at 1.5 and 3 Teslas, and they don't need to be removed. The nice thing about axonics specifically is the remote control. It's very easy to use. You can hold it with one hand, operate it with one hand, and it's simple. It's just an upper arrow and lower arrow to increase and decrease the stimulation and turn it on and off. And it's small, can be placed in a pocket, and doesn't need recharging or anything like that. So here's testimonial from patients that use the rechargeables. As mentioned, it's easy. It can be done while you're watching a movie or reading a book. A clinical study showed that 89% of patients achieved clinically significant improvement in incontinence symptoms after 1 year. So that's a pretty good percentage of patients. And besides the improvement in symptoms, similarly, over 90% of patients after 1 year were satisfied with the results, and they would undergo the therapy again, knowing these results. Another testimonial that how much impact in the patient's life they have. Actually, I've had many patients telling me that they got used to for so many years to certain lower quality of life, meaning that waking up 4 or 5 times at night. So this is part of their life. So they just couldn't believe it that now, after getting sacral neuromodulation, they either sleep throughout the night or wake up once, or they used to, part of their routine having pads in their purse or anywhere you go and change it a few times a day, and whereas now they could just go without it, or like just with a penny liner. So if you have any of these symptoms, then recommend to get a consultation to see, as we mentioned, a baseline, get an assessment, because there are different reasons for leakage, and you can see if sacral neuromodulation axonics is good for you and you're a good candidate for that. And as I mentioned, specifically for that therapy, the trial is very unique because there's really nothing to lose, unlike any other therapy in medicine that we do with, like, we do it and then see how the results are. This one, there's a trial that you can see ahead of time what the results would be. So with that, I come to the conclusion of the presentation, and I want to thank you for joining us. And I would like to open the floor for questions, Q&A, and we'll hand it over to Lindsay. Thank you very much for your time. It's been a pleasure, Lindsay.
Great. Thanks so much, Dr. Kaaki. We really appreciate hearing from you and your experience with treating patients with or who have been suffering from bladder and bowel dysfunction. We do have a question already that came through. So the question is, if the trial works, why not use it instead of the implant?
So the trial, good question. The trial is only temporary. So we mentioned that when we put the lead, it goes through a needle, but it's not connected to anything. It's just taped to the skin, and it's coming out of the skin, and it's connected to the stimulator, like it goes around the waist. So after a few days, this temporary lead eventually will move because it's just taped to the skin. So regardless whether it works or not, after 5 days or so, we simply remove the tape and pull out the wire. And for the patients that works for them, which is going to be more than 3 out of 4, then we'll go ahead and put the implant under the skin with a similar lead. However, the permanent lead has tines that keep it in place and won't move. But because we're going to put the implant under the skin, we need to make a 1-inch incision under anesthesia. And the lead placement that we put in, we want to put it very accurately. So the one in the office is just giving a rough estimate. When we put the permanent implant, we use what we call fluoroscopy or radiology, X-ray, to know exactly where the nerve, and we put the lead next to the nerve so that we will need very little stimulation, and that will make the battery last longer. So very good question.
Great, thanks for that question. We do have one more question. And again, if you do have questions, they're anonymous, just feel free to pop them in the chat. So this question is, if I have frequent trips to the bathroom, am I a candidate for therapy?
It is possible. So just like we mentioned, it's important to have an assessment first, and do, like, for example, a urine test to make sure there's no urine infection. If there, do a bladder diary to assess the bladder function in general, and discuss some lifestyle and behavioral modification. If someone is drinking over 100 ounces of fluid a day, then we need to address that, because no therapy is gonna be working if someone is overdrawing with too much fluid. That fluid is gonna leave the body no matter what. If these conservative therapy fail, then I recommend to move into the advanced therapy, specifically sacral neuromodulation, as I mentioned, as it is superior to the other therapies available, because it's really addressing the issue at hand, which is the neurological component of the problem.
Great, thank you so much. So I don't see any additional questions at this time. So that will bring us to the end of today's webinar. Thank you again, Dr. Kaaki, for your time today. Thank you to everybody who was able to join. I really hope that you found the presentation helpful. If you would like more information or to schedule an appointment, please call Dr. Kaaki's office. You can find that information online, but the number is 844-400-2236. Again, that's 844-400-2236. I felt like I was on an infomercial just there. But yeah, so please call Dr. Kaaki's office and schedule a consultation if you think that this therapy could be right for you. So thank you again. Have a great rest of your evening.
Thank you. Have a good night. Bye.
Take care.